I'll be presenting on the topic the role of insulin-like growth factor 1 and postnatal growth failure in ROP in babies weighing less than 1500 grams. So hormonal production and systemic IGF levels also play important role. Now what happens in preterm birth is there is a rapid fall in the serum IGF-1 levels because the maternal sources are lost. So IGF-1 levels then slowly rise after preterm birth. So greater the duration of low IGF-1, greater the retinal hypoxia and elevation of IGF levels, and more severe the ROP. So there are studies in Western cohorts showing low postnatal serum IGF-1 levels are associated with ROP. Also slow postnatal weight gain, surrogate measure for serum IGF-1 also leads to severe ROP. However, there are limited research on the Indian cohort of preterm infants concerning these factors. So considering this background, we have undertaken this study to estimate the incidence and determine the perinatal risk factors of ROP and determine the role of IGF-1 and postnatal growth failure in predicting ROP development. Our sample size estimated was 329. It was a prospective cohort observational study, and the inclusion criteria was birth weight less than 1500 grams and preterm babies less than 34 weeks of gestation. Weekly serial birth weight was estimated and monitored using growth charts as shown here on the right side, and growth failure was defined based on a Z score. So fall in weight Z score at 36 to 40 weeks of post-menstrual age of more than 0.8 compared to the weight Z score at birth was defined as growth failure. As you can see the rightmost chart, the graphs, you can see a front-end chart, the growth failure is diagnosed based on the values in the chart. So blood sample collection for IGF-1 was done between 30 to 33 weeks, and ELISA was done to estimate the IGF-1 levels. So each baby was categorized based on ROP, highest stage of ROP in either eye as no ROP or ROP. ROP was again divided mild ROP which required follow-up every 2 to 3 weeks, moderate and severe ROP. Moderate ROP required follow-up every 1 to 2 weeks, that is type 2 ROP based on 80 ROP, and severe ROP was the one which required treatment, that is type 1 ROP. So we had incidence of 49.5% ROP in our group, and ROP stages there are 163 babies, stage 1 in 71, stage 2 in 82, stage 3 in 9, and aggressive ROP in 1 baby. So on the univariate analysis, association with ROP development was seen with the conventional risk factors which you always study: gestational age, birth weight, respiratory distress, low of the score. So the new risk factors which we wanted to study are the low weight gain per week, postnatal growth failure, and IGF-1 levels. They also showed significant association with univariate analysis. So this was a non-normal distribution for gestational age among the babies. We could see across two groups, median gestational age was more in the no ROP group compared to the ROP group, and divided into 3 groups based on severity. Again we could see it was significant difference across the groups. Birth weight also had a non-normal distribution, and median birth weight was higher in the no ROP group compared to the ROP present group, and across the 3 groups also it was statistically significant difference. Weekly weight gain was also showing non-normal distribution, and we could see across the 3 groups it was no ROP group it was high compared to the moderate and mild ROP groups, and media of IGF-1 levels also was higher in the no ROP group, 28 compared to 18 in the ROP present group. And across the 3 groups also you could see no ROP group it was highest, 28.81 nanogram per ml, and compared to moderate to severe ROP group which was 20. Again postnatal growth failure was seen more commonly in the group with ROP present compared to the no ROP group. So multivariate logistic regression we did, and we could see postnatal growth failure and IGF-1 maintain the statistical significance with ROP development. We developed ROC curves to get a sensitivity cutoff for IGF-1 levels. We could find 25.56 nanogram per ml was the cutoff for ROP, and weight gain per week 107.2 grams per week was the cutoff for weight gain per week for ROP. A relation between postnatal growth failure and IGF-1 wanted to see in a study, got a negative correlation. Higher the IGF-1 levels, the postnatal growth failure was not present, so it is a negative correlation. So these are similar studies done on previous studies on IGF-1 levels. And you could see our current study, we have done almost 200 babies, one of the highest sample size, and the results are almost similar, but this is the only study done in Indian cohort of babies. And also weight gain per week, we could show similar results of 100 cutoff levels across the studies. So one limitation of the study was our group included babies less than 34 weeks. So 34 to 36 weeks, then in those babies actually the oxygen plays a more definite role than the IGF-1 level. So our results cannot be generalized in those larger size babies. So to conclude, lower IGF-1 levels, poor postnatal weight gain, and postnatal growth failure can act as predictors for ROP onset and severity. And we got a cutoff of 25.56 nanogram per ml for IGF-1 levels and 107.2 grams per week for weight gain per week. So future studies we can use IGF-1 levels, postnatal growth failure or weight gain per week based ROP risk prediction models for predicting ROP severity, and close follow-up of those babies who are high risk of developing ROP rather than following up all babies, premature babies. Thank you.
Excellent cohort. I just wanted to know that what is your take-home message from this now?
Take-home message is actually we should also look for the postnatal growth failure, and because these are not the conventional risk factor which we study. Usually the low weight gain, at birth only we stop it. So we should follow up the growth of also these babies. And in this study we also want to see that the IGF-1 levels, whether they correlate with the postnatal growth rate or not. So we have seen a negative correlation, higher the IGF-1 levels, lower the post and the vice versa. So if future, actually the ROP screening is a big burden compared to the number of retina screening retinal surgeons present. So if we can identify those babies based on this postnatal growth failure, some ROP risk prediction models we can make, we can just closely follow up those babies rather than following up all the babies, and we can space off the, now we monthly we follow up those babies who don't have ROP. If we have the prediction model, we can maybe space off this screening further and only concentrate on babies who have the high risk based on this.
And do you think that with such a high incidence of ROP that you have over here, was there any other factor that you could elucidate for this very high factor?
We had a high incidence because we have only selected babies who are less than 1500 grams. Because if we take up to 2000 grams, which is the Indian convention, we cannot get enough number of babies in the severe group. So just to compare across the groups, we have cut.
No, my question is that why have such a high incidence? Those were not screened, na? They had ROP.
They were screened, all of them are screened.
No, but they were ROP, they had ROP.
They are some stage of
So
ROP.
why high such a high incidence of ROP with you?
Because we got the incidence of the cutoff was less than 1500 grams in our study. So in those group we had a higher.
So any other common factor you had in these babies to have such a high incidence of ROP? I am talking about the pre. I mean, was there any other factor?
No other factor. Only the birth weight we
only
the lower cutoff. So it was intentionally taken so that we get more babies.
That I understood. But did you find any other
no other
incidents? Because there are various studies on ROP which do suggest that there are certain pockets or there are certain, treatment protocols which have led to higher ROP incidence. So this again, IGF-1 levels is also one part of it. No?
Yes.
This is post. And then there are others which are pre. So what I wanted to ask you was that now that you have such a big cohort in comparison to the other studies, did you try and find something which was pre also to improve the or decrease the incidence of ROP basically?
Actually, if you see, this was only, any stage ROP was 50. The treatable ROP had only 79 out of the 300. So, just in that case, thank you.